Hello, my name is Kyrie Henry, and I'm one of the first-year pharmacy residents at AU Medical Center and the University of Georgia College of Pharmacy. Today I'm excited to tell you about my research project in which I investigated insurance status as a determinant of time and therapeutic range within a pharmacist-managed anticoagulation clinic. Neither myself or the members of my study team have anything to disclose. As a brief background as to the why of my research project, we know that patients with atrial fibrillation, or AFib, are at an increased risk for thromboembolic events. It is also well established that the risk for stroke or systemic embolism can be significantly reduced through therapeutic anticoagulation. For patients who are anticoagulated using vitamin K antagonists like warfarin, both the safety and the efficacy of these agents is dependent on the maintenance of therapeutic INR values. The literature suggests that patients with time and therapeutic range, or TTR values, less than 65% are at an increased risk for stroke, systemic embolism, major bleeding, and mortality. There are many factors that play a role in the maintenance of high TTR values, most importantly of which is adherence, which can be an issue for patients who must follow regular dosing regimens typical of warfarin therapy. Other influences include drug or food interactions, alcohol, marijuana, and regular attendance at the anticoagulation clinic for INR checks. Patients with lower socioeconomic status may have issues with warfarin therapy, as these patients may have lower levels of health literacy. So they're unable to follow those complicated dosing regimen, they may not have reliable transportation to the clinic, as well as a variety of other societal factors. The purpose of my investigation was to see if these patients are experiencing poorer outcomes as a result of their socioeconomic status. The purpose was to look at TTR and stratify based on insurance status. We could then use the type of insurance, or the lack thereof, as a surrogate marker for the patient's socioeconomic status. This was accomplished via retrospective chart review, and we were specifically looking at patients with AFib who would qualify for non-vitamin K oral anticoagulants, or NOACs, which was accomplished through our inclusion and exclusion criteria on the next slide. We included adult patients with a diagnosis of AFib who were followed at the Augusta University Anticoagulation Clinic for greater than or equal to 12 months. They had to have documented insurance status so that they could be stratified appropriately. And then we excluded patients with mechanical heart valves, documented moderate to severe mitral stenosis, and those with a target INR range outside 2 to 3. The primary endpoint was time in therapeutic range, or TTR. This was analyzed using ANCOVA. ANCOVA is an analysis of covariance, which is essentially a blend of ANOVA and regression. The covariates that were examined in our model included age, race, gender, CHA2DS2-VASc scores, bioprosthetic heart valves, mitral stenosis, atrial flutter, and BMI. We had both a simple and a final ANCOVA model, and the final model contained insurance status and the covariates that provided the best model fit. The secondary endpoint was hospitalizations related to bleeding or thromboembolism, and no further analysis was performed on this data. 2,225 patients were screened between January 1st, 2011, when the anticoagulation clinic became a pharmacist-run service, and December 31st, 2018. It was estimated that a sample size of 234 patients, or 39 in each group, would be required to meet power, and unfortunately, only 173 patients met inclusion and exclusion criteria, as well as the minimal INR reading requirements. Data was collected and TTR was calculated using the Rosendahl method. Rosendahl is the most commonly used measure of TTR in literature. The primary endpoint was TTR stratified based on insurance status. The 6 insurance groups are shown below: private, Medicare plus private, Medicare, dual eligible, meaning Medicare plus Medicaid, Medicaid, and then our uninsured or indigent care trust fund, or ICTF patients. ICTF is a Georgia social program, which is an expansion of Medicaid where uninsured people who don't qualify for Medicaid may receive health care from participating hospitals. ICTF patients can receive care from AU Medical Center as we are a disproportionate share hospital, or DISH hospital. My hypothesis was that patients in the Medicaid and uninsured/ICTF groups would spend less time in therapeutic range when compared to patients with private insurance. The baseline demographics for my study population are shown below. You'll notice that some of these factors are more reflective of a Southern academic medical center rather than the study populations used in warfarin or NOAC literature. The patients had a mean age of 70 years and were split approximately 50-50 male and female. The patients were approximately 50-50 white and black, with a 3% Hispanic population. The average BMI was 32. 4 and 6% of our study population had mild mitral stenosis or bioprosthetic valves, respectively. The mean CHADS-2 was 3 for comparison to literature like Aristotle or Rocket AF, and the mean CHADS-VASC was 4.5. There was a wide range of follow-up and number of INR measurements, with an average follow-up of 52 months and 9 INR measurements in a 6-month period, which is approximately once every 3 weeks. The mean TTR for this cohort was 62, but the average overall TTR for patients followed at the AU Anticoagulation Clinic is upwards of 75%. My informal hypothesis was that TTRs across each group would follow this general trend, with descending TTRs from private all the way down to the uninsured or ICTF group. The results of both the simple and final ANCOVA analysis are shown below. Starting from the left-hand column, note that the private, Medicaid, and uninsured/ICTF groups were underrepresented in the sample of patients. Remember that we needed 39 patients in each insurance group to meet power. You'll note that the general trend from my informal hypothesis is present in the simple ANCOVA analysis. Patients in the private insurance cohort had the highest TTR, and those in the uninsured or ICTF cohort had the lowest. Using all the covariates previously described, there was no statistical difference observed based upon insurance status. In the final ANCOVA analysis, again that general trend from my informal hypothesis was shown, with slight changes in the TTR in each group. Using the covariates that provided the best model fit in the final ANCOVA analysis, the largest changes were observed in the dual-eligible, Medicaid, and uninsured cohorts. These groups were adjusted to TTRs of 67, 66, and 56 respectively. No statistical difference was observed in the final ANCOVA analysis, with a p-value of 0.08. While there was not a statistically significant difference observed between cohorts, there were several groups that had TTR values less than 65%. Again, the general trend was that this was observed in cohorts with lower associated socioeconomic status. Remember that the secondary endpoint was hospitalization related to bleeding or thromboembolism. Only 2 events were captured in this patient cohort, and both were bleeding events within the Medicaid group. Because the number of these events was so small, no further analysis was performed. The objective for my presentation today was to answer the question, how does insurance type influence TTR for patients who are anticoagulated using warfarin? The general trend observed in my investigation is that using insurance status as a surrogate marker for socioeconomic status, patients with higher socioeconomic status spent more time in therapeutic range. As shown in my results, uninsured or ICTF patients had TTR values less than 65% in both the simple and final ANCOVA analysis. From this, we can conclude that these patients would likely benefit from being transitioned from warfarin to NOAC therapy, as these medications require less lifestyle modification, have limited drug or food interactions, and limited laboratory monitoring. Thanks for viewing my presentation. If you have any questions, feel free to contact me using the email listed below.